comments on how fluoride messes up with TSH, T4, T3.
Hello. Fluoride. Okay, well, fluoride is one of the most volatile elements on the entire periodic table. In fact, it is such a violent element that if you put it in the water, you can actually make it burn. The toxicity of fluoride has been well documented since back in the 30s. It was used by both the Germans and the Italians, and they reported it in 1936, that you can use fluoride to treat hyperthyroidism. And the doses of fluoride that it takes to cure hyperthyroidism is the same as we're putting in our public water system at the moment. So we are giving an effective hyperthyroid treatment to our entire population, and then wondering why Americans are tired, dumb, and depressed. Just small doses of fluoride actually cause a great deal of trouble with thyroid function. Now, one of the other interesting studies, if you go on YouTube and use the keywords Calgary and mercury, you will see a nice demonstration of where they took a neuron and watched it assemble itself. And what you see is that the neurons have these long strings, and then you have these various assemblies of amino acids that are assembling on them, very much like you're putting pearls on a string. And then you introduce just a few molecules of mercury, and you'll see the entire neuron begin to disassemble itself. So that's a very graphic way of watching with your eyes what happens with very small amounts of mercury. Oh, that's mercury. We were talking about fluoride. Sorry, it's late in the day. I guess I got a little off track there. But the point is that fluoride is similar in its effects in that very small amounts of things disassemble things. Fluoride will attack collagen any place the collagen exists. And so one of the things that is of some interest is to look at what happened with coronary artery disease. When Paul Dudley White brought the German EKG machine to Boston in 1920, his colleagues said, well, that's very interesting, Paul, but why are you fooling with that? Nobody has heart disease. Well, things have changed since 1920, and if you look at the graphs, the amount of coronary artery disease corresponds very nicely to the amount of fluoridation of our water supply. The other thing I did was that if you go online, you can very easily obtain the data of the percentage of populations in each county in the United States that have fluoridated water, and you can also get the data for obesity. And what you'll see is that the lines are almost identical, that the more fluoridation we've done, the more obesity we have. And it relates to the number of people in the counties. The other thing is that the studies have been done showing that fluoride will displace any other halogen. So if you put a molecule or an atom of fluoride in the same neighborhood as an atom of any of the other halogens, then it will displace it. So if you take T4, which is tyrosine with 4 iodines on it, and expose it to fluoride, then you end up with a tyrosine with 4 fluorides on it, which can measure as normal thyroid, but it doesn't work. So if you want to look at the list of the similarities between thyroid dysfunction and fluoride dysfunction, there's a website that has literally a couple of hundred journal articles showing the same problem happens with fluoride that happens with hypothyroidism. And if you can't find that, send me an email and I'll send you the list of it. So again, fluoride is one of those toxic substances that has been shown over and over again with literally hundreds of published articles about its toxicity.
Follow up on that question. Does it matter if it's in your water, like systemic, versus we as dentists are using them in our restorative material, topical? If you're swishing it and spitting it out, I just wondering from a medical point of view. I mean, some of that probably gets absorbed definitely in your body, but I didn't know. I mean, I had a patient who wanted fluoride-free restorative material, and I didn't know. I did some investigative work from the manufacturers, and most all of them told me that there's no such thing. All the adhesives have fluoride, all composite, until I actually found out today that there is a company here that is actually offering that. So I just want to know, topically versus systemically in the water, makes a difference, you think, or not really?
Is that question for me or someone else on the panel? You know, it's an interesting question that's probably not been terribly well studied, but there are some suggestions out there. For example, there's a group of antibiotics called the fluoroquinolones, and the best known of those are Cipro and Levaquin. And there are plenty of examples in the literature of people who've taken one capsule of a fluoroquinolone and had their Achilles tendon rupture. I have 3 patients in my practice that took one series or a part of a series of either Cipro or Levaquin, and they're totally disabled now because their brain won't work anymore. And so there are people like Jerry Smith, for example, many of you know, who is active in creating homeopathics of those drugs and can reverse it, but that's the only way that either he or I know how to do it, how to take such a disabled person and get them back. But the point I'm making is that when you put a fluoride molecule in a fluoroquinolone antibiotic, it can destroy a person. Anybody else want to talk about it?
I don't know about the transdermal. Each compound is going to have different transdermal absorption, but you're not likely to have volatility. It's not like mercury where it's going into the air and you have a vapor field of it. So I wouldn't worry about it that way, especially the water-bound stuff. But transdermal would, wear gloves and stuff. I don't think it's going to reach out and get you. You'd have to kind of rub it on.
I have a question for Dr. Schallenberger about the ozone. When you do the rectal insufflations, does it affect the beneficial bacteria in the gut, or is there no effect, or is there some effect and you have to repopulate, or what are your findings?
Well, yeah, it does affect the beneficial bacteria because the beneficial bacteria are primarily aerobes. There are some beneficial anaerobes, but primarily they're aerobes. And the problem that people run into is not that they have anaerobic bacteria in their gut, it's that that's the preponderant bacteria. There's an imbalance of bacteria. There's always bacteria in there. It's just a question of is it going to be balanced or not. And I think that being as how we never see any problems created by putting ozone in the rectum, but we always see problems get better. Also, when you consider the fact that an anaerobe is not going to have any defenses against an oxidative stress. None. It has no defenses. It can't even deal with oxygen itself, much less something as strong as ozone. And aerobes, by their very definition, have to have antioxidant protection systems. So basically, you take somebody that's got an imbalance of bacteria, and you inject ozone into that area, you'll get rid of the ones you don't want, and that'll leave the ones that you do want to be stimulated, and reestablish the balance. Okay.
That you should be implanting more beneficial bacteria after the treatment?
Well, yeah.
Necessary, or
you know, I more or less use probiotics all the time, and fructooligosaccharides a lot, and you know that your diet's important too. So, you know, we want to pay attention to all that stuff. But I'm kind of a believer in telling my patients, you know, once or twice a week, take some sort of probiotic, just as a matter of course. You know, actually, we do use rectal implants of probiotics in the colonic. So the colonic therapist at the end of the therapy does do an implant like that.
After the ozone?
Yeah, after the ozone therapy. Yeah, absolutely. And she's got some other stuff, like she's got some algae in there, and I don't know what else she's got in there, but good.
And one other question. You recommended using all the different routes of administration of the different types of ozone. Do you do that all on the same day, or do you stagger it?
No, yeah, so we can do it all on the same day. We can give you a blood treatment. After you get the blood treatment, you go and you get your colonic. After the colonic, you go over there, you get a sauna. After the sauna, you sit in there, we're shooting your ears up. And then after you got all that done, you come into my room, and I'm going to shoot your neck up, and then you're out of there. Absolutely, you can do it all.
The question is, when you remove an amalgam and the mercury remains in, does the mercury remain in the tubules of the tooth? It almost looks like an amalgam tattoo underneath an old amalgam, as well as when you have an amalgam tattoo in the tissue, because patients have asked, is there mercury in my tissue, or is there mercury left over, even though there's no visible filling, amalgam filling?
Sounds like me. You are. Yeah, there's got to be some in there. But it's a good question. Like, where does it go? How long does it take to come out of there? What are you left with? I know a lot of people, when we put them on a detox, complain about pain in the jaw where the amalgams were, or where certainly if there's ever a tattoo, they complain about a problem there. But, I mean, it's almost like you're asking about detoxing the tooth. You know, what do we do to get it all out of the tubules? And I guess it's just going to slowly diffuse out of there and be taken up by your detoxification systems and gotten rid of. It's probably one of the slow release areas of the body after you do a removal, but it points to the importance of really grinding it out well without compromising the structure of the tooth, getting as much material as you can that was touching that amalgam.
Mike?
So what you're saying, when the patients do ask, you know, medically compromised patients will ask that question because they're very fearful of even a minor amount of mercury left in the tooth. So my answer would be, yes, there is mercury, and with the proper detox, it should eventually
with the proper detox, it's going to dissipate, and it'll be slow just because of the nature of the tissue to come out. But you know, it's then important to get the right detox and not think it's going to be a week-long detox. It's a long procedure, especially if you've been physically compromised. Your experience with detox might be a year, 2 years, 3 years.
Okay, I was just going to ask that. How long would the detox be? So you're saying several years?
Well, the healthier person can go. There's what I call the intensive detox phase, and then there's the slow maintaining the system working well, maintaining that momentum. And for the very sick person, the intensive period is going to take much longer because the whole procedure is starting with low doses of whatever you're using and working up the higher doses, and that titration time takes much longer in a very compromised person. They might, like if somebody's fine, they can start at a full dose to begin with and work up to 4 doses over 5 months, but a sick person's going to start with 1/4 of a dose, 1/8 of a dose, and it's going to take a year to titrate up to something relevant. So I think that they should be thinking in terms of supporting that system over 1, even 2, 3 years. The sicker they are, the longer the process is, with a sort of 5-month minimum.
Remember that the traditional chelating agents do not go intracellular. They can only attach to extracellular heavy metals. And so that's one of the big disadvantages. Plus, if you're using oral, when you give an oral thing, whether it's DMPS or any of the other similar ones, they go through the liver, and it's quite common if you follow your liver enzymes that oral chelating agents will make your liver enzymes go up significantly, and so you have to watch that.
They're detoxified by the liver, but they're dragging the metals primarily through the kidneys. So you've got
but your liver enzymes do go up.
Yeah.
Yeah, and that's my point. Is if you put somebody on oral chelating standard pharmaceuticals, then if you don't watch your liver enzymes, you could get into trouble because those can get quite high with oral. Now, a much safer approach, in my view, is to use concentrated fulvic, FULVIC. That's been done for many years in the veterinary and agricultural communities. And so the nice thing about fulvic is you can get it in a 400x concentration. And it will go intracellular. It will grab the metals and pull them out, deliver them to the gut. But you want to have humic in the gut because the humic are large molecules that stay in the gut. Fulvic are small molecules that go out and harvest the metals. So you want a combination of humic fulvic in the gut, 400x fulvic to go out and harvest the metals and deliver them. And I've never seen any liver enzymes go up. I've never seen any creatinines go up. I've never seen anything go amiss when you're doing that. Now, I can't guarantee you that it's an accurate system yet, but the system that we use to follow that is called the oligoscan. It's a spectrophotometer that reads the... You don't like the oligoscan?
Oh, you're hitting a raw nerve there.
So, again...
I'll talk about it for a while if you want.
Again, I told you that I'm not certain that it works, but the things that I've done with it, comparing it to urine provocative tests with DMPS, is that it gives me very similar readings. So again, I'm not positive yet how well it works, but when we do both, we get essentially the same reading, and it's certainly much easier. Obviously, somebody here disagrees with what we found. So there you have it. But consider fulvic. It's a much safer way of doing things than, particularly than oral or IV chelation.
And I've seen a lot of interesting work with fulvic. It doesn't have the thiol groups necessary to bind metals, but it might not be binding them directly. A lot of the things when we look at when I teach about detox, there's squeezing the cell to get the intracellular metals into circulation, then there's filtering the circulation. Filtration is taking place from the kidneys, liver, and GI tract, and then how are you going to squeeze out of the cell? You need to invoke mechanisms of the cell involving the glutathione system to bind the metal and shuttle it out of the cell. Fulvic directly, I don't see the chemistry how it can do that, but it may hit one of the triggers that turns up your expression of the glutathione system. much like we used to say that garlic and crucifers were sulfur compounds and thus they would chelate the metals. It turns out they're not chelators at all. They just stimulate your expression of the glutathione system. So it may be something along those lines that the fulvic is doing. But polyphenolic antioxidants, sulfur-based compounds from the crucifer family, from garlic and onion, from wasabi, lipoic acid, though be careful with doses. All of these stimulate the genes that do this. Now, we're at a crossroads in research. You know, we used to be all antioxidant heavy, and now we're pro-oxidant heavy. And the pro-oxidants also hit these triggers to turn up the glutathione system, which is why ozone is very helpful then with metal detoxification. The only thing with the oligoscan you measured, it's a light where they're shining a light on your hand and then giving you a readout of all of your metal levels. Now, the metal levels don't actually have any units. There's just a bar. It's high, it's low. And they claim that it correlates with the measures that they're doing, but nobody's ever published or revealed any of these correlations that they had. And last I was in an analytical chemistry department, we did not have nearly the spectrophotometric power and resolution on the vast amount of light that comes back at us to be able to resolve out these different metals just by looking through your hand, especially the trace metals. But if you have any data, I'd be happy to look at it. Always open there.
If it's okay, I'd like to follow up with the question that was on the other side about I removed an amalgam, my patient's concerned about mercury in the tubules. Can you, instead of having to draw the mercury from the tubules through the nerve into the bloodstream and out through the gut, is it possible to chelate a tooth prep?
I love the idea.
I mean, why go through all the effort to suck the mercury through the tubules?
Well, you're talking about a mass transfer that has to happen through these tubules, and I don't know exactly what form the mercury is in the tubules and how it's bound to different things. You'd need to have it move through with that liquid all the way to where you have your prep. But theoretically, you could pack a mercury sorbent into the prep and it would suck up a fair amount of the mercury in there. But to move all the way out of that solid, you'd really have to like pack that in there and leave it in for a week and then have them come back.
Which follows up with the gaseous form of the ozone because of the greater penetration. Can there be a gaseous chelator that will draw at least some of the mercury out of the dentin tubules before I seal the tooth, where the only exit's going to be into the pulp?
Wow, so you want a gas phase chelator. I could give you one, but it smells like skunk, and your whole building will reek, and your patient will hate you.
But something like that.
But it's theoretically possible. I would lean towards, like, if you wanted to go down that route to get solid phase sorbents, thiol solids, and pack them in there and cover them up and leave them in there for a certain amount of time, and then take them out and put your real restorative in there. That's pretty radical. I like that. I don't know if it matters, but it's.
Dr. Tennant, in your presentation in bioterminal mode for emotional issues, would that work for patients who have fear of dentistry?
I have no idea is the short answer. First of all, let me just say that I only figured out how to use the frequencies to get rid of this within the past few weeks, so my depth of experience is short. What we do find is that the emotion that's attached to a memory can be erased fairly easily once you identify the emotion and have the person think about it while you deliver the corresponding frequencies. That seems to work essentially every time we do it. Now, if a person is afraid of a dentist because of a past experience, then theoretically you could erase that emotion and they would no longer be fearful. But that's theoretically, I have no experience with it.
Dr. Dunbar? Could you speak to appliance design for children and their snoring? And also, you mentioned just a little bit about ADHD and kids.
I've not really dealt with appliances with children. Children that snore, the main form of therapy is going to be tonsillectomy and adenoidectomy. It's going to be rapid palatal expansion. Ideally, you want to have breastfeeding taking place. And then if you've got a low tongue level, tongue tie, like from the what I was showing, it's a premature child, then you're looking potentially considering myofunctional therapy. But at this point, to try and do an oral appliance on a child, I mean, I'm not going to do it. The youngest I've treated is 16 years. And I'd probably, to go any earlier than that, you're going to be looking at probably an orthodontic evaluation with it, because you're going to get some morphological changes given time, I would assume, with someone that young. But really, for snoring, I mean, you're looking at tonsillectomy, rapid palatal expansion, myofunctional is going to take care of a large amount of that. As far as ADD, did you come to this afternoon, the seminar this afternoon? Oh, okay. What they were saying with that is that mouth breathing, snoring, that major study out of England with 11,000 kids over 6 years, it was really showing that that's really been associated with neurocognitive deficits. So that's where a hygienist simply talking to mom or dad or grandmom, finding out if that child is snoring or showing, mouth breathing, that's when you can get them into the appropriate referral system to get those children treated.
Quick question, Dr. Schallenberger. On your list of ozone treatments and modalities, did you say that one of the ones that you don't treat is hyperthyroidism?
Yes, so hyperthyroidism is a hypermetabolic state. Ozone's a metabolic stimulant, so you conceivably can throw them into a thyrotoxic state by doing that. And that's actually been reported, so it's more than just theory. So that's one hard indication. No Graves' disease. You're not going to give ozone to Graves' disease. Hashimoto's is normally hypothyroidism, but if they're in an acute hyperthyroid state, no ozone.
Question, and this question is going to be directed to Dr. Dunbar, Dr. Schallenberger, and Dr. Tennant. Regarding oropharyngeal and immune system reaction, enlargement of the tonsils and adenoids, as a dentist doing a lot of TMD and watching my kids and addressing the airway and all of that, I became keenly aware of how important airway is in craniomandibular development. And as a holistic dentist, I was struggling not to remove the tonsils and adenoids. And I've been struggling with both sides of the fence quite a bit, because obviously the tonsils and adenoids create a tremendous amount of orthopedic damage, and yet they're immune, part of the immune system, and T killer formation and all of that. So obviously the traditional path is tonsillectomy and adenoidectomy when it's interrupting the growth. For my kids, I chose not to do that. It was a tough choice, but we went the wrong path, long path, but the correct one for my kids, at least. If you gentlemen can elaborate on ways to boost the immune system and address the cause of the problem. Somebody told me that when you have a fire, you have a lot of fire trucks, and so tonsils and adenoids are reacting to the something pattern of allergy, inflammation, whatever. So do we get rid of the tissue that is responding, or do we address the cause? And sometimes it's really not easy at all to address it. So I'd like to know about the answer.
If I have a kid with swollen adenoids and tonsils, the sooner I get them, the better results I'm going to get. One really good thing is to take some ozone, about a cc of ozone, and inject it into the tonsillar pillars. That can work really well. Another one is to give them zinc lozenges to suck on frequently. That could knock it down. Look at their overall immune system. Try and work that. Give them things that are antiviral in context. I particularly like zinc because zinc in its ionic form knocks out viruses, and typically these are viral issues. And the nice thing about a lozenge is it's a continuous application of zinc to that area topically. So the zinc lozenges, zinc acetate in particular, second to that zinc gluconate, will get a pretty good result that way. Look for food allergies, of course, and take them off anything that's potentially has a food allergy. What else? That's about all I can think of. If I do that, I'm probably going to send maybe 1/3 of those kids to surgery. I could probably save most of the kids by doing something like that. Say again?
The turbinates, what are you doing for that area that's inflamed?
Oh, turbinates. Okay, so this works out great. You take ozone gas, and you're going to use a 20 gamma, and start off slow. As a kid now, so you're going to go pretty easy. Probably just going to go like maybe 5 cc's at a 10 gamma at first, and I take a butterfly, and I cut the needle off. And so I've just got attach it to the syringe. So then I put that little tube in the nose, about 1 inch up the nose, squeeze the nostrils closed, and get the kid to hold his breath. Hyperventilate a couple of breaths, hold your breath. And then while he's holding his breath, I inject the gas up into the nasal cavity. And I let it sit there for about a count of 10, 15. And then I tell him to exhale through the nose, blow all the ozone out, because there's going to be some ozone left. It's not all going to react instantaneously. And I don't want him inhaling any ozone. So once I've done that side, then I do the other side. And then I'll do that maybe 3 times. And you do that on day 1, repeat it on day 3. You probably cleared that up right then and there.
One thing that I'm finding is, and I'm not sure of the exact study, but they're starting to find in children elevated CRP levels comparable to adult cardiac patients. So when you're dealing with a child with sleep disordered breathing, mouth breathing, snoring, etc., I mean, those children's results, when you start looking at elevated CRP levels comparable with adults, that to me is scary over a long-term scenario. So I can't speak on what the gentleman here is saying. I'm sure that, I'm sure I'll be on board with that to a great degree. But in general, when you're looking at a child, to me, like with my granddaughter, when that tongue is hanging out because there's no room for the tongue in the mouth, to me, using coblation, which is a lot less invasive than removing the tonsillar sac, yeah, I'll get rid of the tonsils and adenoids and then go from there. That's just my own personal opinion.
First of all, if a tongue is enlarged, then that is hypothyroidism till proven otherwise. And if you look for hypothyroidism, even in these smaller kids, you'll often find it. You have to remember, though, that the TSH is an extremely unreliable test. What you want to know is what is the free T3 and the ratio between free T3 and reverse T3. If you get that right and support their adrenals, then oftentimes that part of the problem goes away. But the main thing I wanted to mention in addition is that the immune system's first line of defense is iodine. If the body has enough iodine, it will put 30 times as much in the parts of the body exposed to the outside world as in the blood. And of course, the obvious reason for that is surrounding the body with a shield of iodine then prevents infections from entering the body. So almost all of these kids are iodine deficient. And if you begin to correct their iodine levels, you'll find most of these chronic upper respiratory things simply disappear. And of course, there are many other reasons you want to correct iodine. For example, Frank mentioned that you want to deal with food allergies. Well, food allergies are caused by lack of stomach acid. And the reason is that when you eat a protein, stomach acid has to break it into amino acids so that you only absorb amino acids. The human's designed to never, ever absorb protein. The primary reason for that is that it's the only way the immune system knows what's you and what's not you. So you have a database in the thymus gland, which of course sits here just behind the sternum. And when white cells go through the database, gets downloaded into the white cells, and the white cells go cruising around the boulevard, and they bump into a protein, and they check to see if it's in the database. And if it's in there, it says, "Oh, you're me, have a nice day." And it goes on to the next protein, and it bumps into that one, and it says, "Oh, you're not in my database, you're a bacteria or some other thing here to hurt me," and it calls in the immune troops, which builds antibodies and attacks that protein, trying to destroy it. And if it can't destroy it, it stuffs it in fat cells. So when you eat a protein and you don't have stomach acid, then whole proteins go downstream, and you become allergic to everything you eat. So the key to fixing that problem is to have adequate stomach acid. So what's it take to make stomach acid? It takes 5 things: vitamin B1, iodine, zinc, salt, and the voltage to make it. And so, of course, the voltage in the stomach meridian is controlled in part by whether or not you have infection or decay in the upper molars or lower premolars, because that's what is on the stomach meridian. So the point is, iodine deficiency is a major cause for immune deficiency. And if you don't fix that, you're going to not only become allergic to everything you eat, you're going to get lots of recurrent infections, including upper respiratory infections. Such a simple thing to do, fix the iodine levels.
You've also got a simple fact that there's only so much room in the mouth for airway. And there, now you need to also check tongue level, see if the child's tongue-tied, if you're dealing with mouth breathing. And so, I mean, once again, there's only so much room in that little area in order for patency. And as I was showing on some of the earlier research, it's apnea, sleep disorder breathing is not dose dependent for a child. You can get very minimal resistance levels, and you don't outgrow it, because some of the research was showing, for those that didn't come this afternoon, that you're still getting about a 40 to 50% recurrence rate when say the symptoms disappear at an early age. When the child gets older, you still got a 40 to 50% chance you're still going to have those neurocognitive deficits, because you didn't get rid of it, the symptoms just went away. So to a great extent, I mean, there's a physical situation when you've got a little tyke, big tonsils, low. If you have a low position tongue, that tongue is down and posterior in the airway. That's why you want the tongue up behind 8 and 9 in that valley between the first 2 rugae to keep it up and out. And then if the child wasn't breastfed and you've got a narrow palatal arch, once again, there's only so much room there. So if you can reduce it with what the gentleman here was saying, that's great. But on an overall general basis, to me, I want to open that airway with rapid palatal, et cetera.
Dr. Tennant, what form of iodine do you think is the best absorbed?
Good question, and I can't give you any, I can't quote any studies for you. But as you know, iodine per se will not dissolve well in water, but does dissolve in alcohol. And that's why Dr. Lugol in 1846, I think it was, found that if you put potassium iodide in water and then added the iodine will go into solution. So Lugol's solution has been around since the 1840s and has continued to work quite well. Now, in recent times, people have started taking iodine dissolved in ethanol and run electric current through it, which makes the iodine smaller, so that you have so-called nanoparticles of iodine, which they claim are better absorbed. And I certainly have colleagues and friends who are using that, and I looked at that for a while, but then I ran across some literature that says the body doesn't efficiently convert iodine to potassium iodide, but does have a requirement for potassium iodide. So for that reason, I abandoned the use of the so-called nascent iodine and went back to what I've used forever, which is Lugol's. So, so again, I can't quote you studies, but my personal preference is to use standard Lugol's.
Second question. Dental implants out of titanium, have you observed that they change the flow of current along the meridians that go through the head?
Oh, that is something that is not as completely easy to measure, in that you can often have multiple things on the circuit that's affecting voltage. Just as I mentioned, scars usually are the first thing that takes voltage down in a circuit, and then you get the decay in the tooth, and then you get a bigger filling and more decay and so forth. So I can't easily separate out. Having said that, my biggest concern about implants, particularly about titanium, is that all metals are electron stealers. So when you put a metal screw in, titanium, it's going to lower the voltage in the surrounding bone. And when you lower the voltage, you automatically lower oxygen, which makes it more susceptible to having microinfections around it. So from at least a theoretical standpoint, titanium would not be the ideal screw material. Now, also theoretically, zirconium itself is carbon, and thus would be electron neutral, and therefore zirconium per se would be a theoretically better solution. Now, I'm aware that the zirconium screws are not just pure zirconium. They are mixtures of various compounds of zirconium. So, but again, I have no data. I only have the general impression that since I've started seeing people primarily with zirconium implants, I see less problems with low voltages in the meridians where people have zirconium than titanium. But again, I have no data. It's just an impression at this point.
And then the third question, this is kind of out there. The current bestseller book about earthing, have you seen any benefit from being out in touch with the earth for, 15 minutes, half an hour?
Yeah, and I've been talking about this almost as long as I've been in integrated medicine, so for years and years. The point is that life could not exist on this planet were it not for lightning. Did you know that? So lightning strikes the earth thousands of times every minute someplace. And when lightning strikes the earth, it goes down into the earth, it comes back out and goes out to the ionosphere and comes back. So the surface of the earth and the ionosphere form a capacitor. And of course, a capacitor is a battery, isn't it? By definition, a capacitor is two conducting elements separated by a non-conducting element. So between the earth and the ionosphere, we have this cavity called the Schumann cavity. And within that cavity, you have multiple frequencies, the most common being, or the strongest being, for approximately 4.8 hertz. Well, access to that particular frequency is necessary for life to exist. If you want to prove that that's true, and this has been done, take and dig a hole in the ground and put people down in that hole, and within about 48 hours they began to go insane as you remove them from those frequencies and from light. Well, the point being that exposure to the Schumann cavity is substantially critical for health. Now, in addition, if you touch that part of that capacitor, namely put your feet or any part of your body in direct contact with the earth, then that you will get a donation of that voltage. So one of the ways that we get charged up is to simply put our feet in the dirt. Now, one of the problems, of course, is that we tend to wear shoes because we don't want to get our feet dirty. But that insulator keeps us from getting that donation. Now, if you look at the concept of earthing and people putting grounded sheets on their bed Depends on how you do it, whether it's going to be helpful or harmful. If you put a grounded sheet on your bed and you actually touch it, then you are going to get donation of electrons if your voltage is subpar. On the other hand, if you put a grounded sheet across your bed and then you put an insulator on top of that, say a thick blanket, and you lay on the blanket, you now have created a shield that separates you from the magnetic field between the Earth and the ionosphere, and thus it's detrimental. So the issue of grounding depends on whether you are really grounded or you're shielded. Did I explain that well enough? So, and you know, I've discussed this with like Jim Oshman, et cetera, and he's aware of this basic concept that you have to really be grounded. I commonly take my patients, particularly those in wheelchairs, and say, roll them outside, take their shoes off, put their feet in the grass, and you'd be surprised how much better they feel in a short period of time just doing that simple thing. The question is, who do you want to answer that? Frank, you want to take that one? Well, the question is, what about pulsed electromagnetic therapy, and how does that affect voltage? I'll give my thoughts and then let Frank finish up, if I may. Probably the person who was the first to define this issue was Schauberger in the 30s and 40s in Switzerland. What Schauberger figured out was that there are two kinds of energy. One kind starts small, spins left, goes big, and explodes and disappears. Whereas the other type of energy spins right, starts big, and comes to a point and concentrates energy. And understanding this, Schauberger was able to develop a flying saucer that used water as the fuel and flew at hundreds of miles an hour at a high altitude, and by the way was kidnapped by the Nazis and forced to work with Werner von Braun during the war. Well, understanding that, what Schauberger taught us was that the transfer of energy requires a pattern that starts big and goes small, which basically means it's dampened, and then does it again. And so, by definition, that's a pulsed electromagnetic field. And therefore, the frequencies that in my device, for example, my device is a PEMF device, because it's the only way you can transfer energy to cell membranes. Having said that, the thing that's different about different PEMF devices is that every organ in the body runs at a different frequency. So not only must you deal with the waveform, but you must deal with the frequency if you want to transfer efficiently to the cell membranes of that particular organ. And that's what we've built into the biomodulator, is the frequencies that, as well as it being PMF, it's frequently selective for the specific organ's frequencies. Frank, you want to take it from there?
We've got one last question.
I'm over here. Hi, guys. Thank you very much. I guess I'm the last guy, so I'm going to say thanks, Paul. Super job. I just thought I'd mention one thing that we were talking about the stomach acids there a bit ago, and I do know there is a supplement that I hear, I'd just like to get your take on it, but I hear does a pretty good job at reestablishing the stomach acid pH, and that would be Zypan. I'm not sure if any of you guys have ever heard of standard process or used the Zypan products, but I thought I'd throw that out there, see what you guys thought of that. And then I thought I'd ask as well about vitamin D and its protective function, and what the blood levels of vitamin D and what significance that. I know it probably has nothing to do with what we talked about at all, but it'd be interesting to hear somebody's comment on that.
Well, vitamin D, of course, is extremely important throughout the body. It is one of the major things that affects the immune system, and particularly as it relates to viruses. There are holes in the cell membrane that viruses go through. Vitamin D blocks that hole so they can't get in. And so one of the things that's quite beneficial in protecting against viral illnesses is to have adequate levels of vitamin D. And the primary reason people get colds in the winter and more than they do in the summer, is that when they're out in the sun, you get elevated levels of vitamin D. When you in the wintertime, you're wearing sweaters and coats and you don't go outside, you have lower levels of vitamin D, and thus the doorways for viruses are wider open. Now that, you can get into certainly more sophisticated explanations from biochemistry, but that's kind of the nuts and bolts of a way to think about it. Vitamin D is turning out to be incredibly important throughout the entire immune system, the way the brain works, et cetera, et cetera. Most people that I'm aware of believe that the vitamin D levels need to be in excess of 50, perhaps 60. And there are some fairly good studies that show that you can get really quite high levels of vitamin D before it becomes toxic. And so the fear that we're going to make people poisoned with vitamin D, to the most part, seems to be inadequate. I measure every patient I see, blood levels, and at least in Texas, where we have a little bit of sun, it takes at least 10,000 units a day for almost everybody that I see to keep their levels above 60 or above 50. Yes. I give it to them 10,000 units a day year-round, and no matter what time of the year I measure them, they're rarely above 70, 75. So now, as far as the Zypan, I have no personal experience with that. I'm familiar with it. What we did do, because digestive process problems are a significant problem, is that I had a biochemist go through and formulate a product that has every known digestive enzyme in it, and instead of using something like betaine to act like stomach acid, in our product we use dehydrated apple cider vinegar, which kind of substitutes for that. If we have time, perhaps part of this discussion should be the fact of how drinking or eating anything alkaline affects both the total body voltage and the voltage in the pancreas. But that's related, but sort of separate. So I'll not go there unless I'm asked to. Who wants to take it?
And I always have patients show up. I put them on vitamin D, and they go and see their internist, and he says, "Oh, geez, your level's up around 70. You better stop that." And I don't know. He's not even looking at the range. The range goes as high as 100. So I want to say it's about a year or so ago. I searched the literature for everything I could find on vitamin D toxicity, and I came up with 2 reports. So it's not that common. The one that I remember the best was a patient in India, and his doc gave him 50,000 unit capsule, and he said take 1 a week. I thought he said take 1 a day. And he was doing just fine until about the 8th or 9th month. And then he started to have an awful lot of symptoms, and mostly bone-related type pains. And his blood level at that point was in excess of 400 nanograms per ml. So it was really, really, really high. And that was after like 6, 8, 9 months. So I think at the doses we're using, and I would concur with you, most people, I've seen a few people get away with 5,000, but I mean the 400 thing is just not happening. Most people are going to need 10 to 20,000 units of vitamin D per day to get up to a good level. The therapeutic level for cancer prevention is roughly around 70 nanograms per ml. And that's been established in several studies. That just seems to hover around that 70. So I think that's your gold standard. That's where you want to go. I have lots of patients who have levels in excess of 70, like, maybe up to 110. I don't really bother with telling them they need to take less vitamin D, because maybe more is better. I certainly never, ever see a problem. Always follow the serum calcium. Do that, okay? You need to follow the serum calcium, because there's going to be some people that are going to develop parathyroid issues. So just watch that serum calcium. But once you've established your dose, if the serum calcium's not going up, you're pretty good, and I think you're on safe grounds there. So the question had to do with vitamin K2 together with vitamin D, and the vitamin K is, it's quite valuable for bone formation, which is probably why you're thinking about this. And I can't comment as to whether or not there's some synergy with toxicity. Don't know that. But so I just get my vitamin D levels to where I want them to be, and kind of like Dr. Tennant, I look at blood levels all the time, just tighter to the blood level. On my vitamin Ks, I don't actually routinely give everybody vitamin K, but I'll do it on the basis of a certain phenomenon. You know what vitamin K will do is it will prevent varicose veins. So varicose veins are caused by vitamin K deficiency. So if you have a history of that, that's a pretty good indicator. Any osteoporosis, pretty good indicator they need vitamin K. Calcification, the arteries get calcified in the presence of a vitamin K deficiency. And so those would be indications. Any calcification of the arteries would be indication for vitamin K. Okay. Lori's got it.
SF